I am Bernard Herschel. Before my retirement, I was the chief of HIV/AIDS at the Geneva University Hospitals. You may call me an AIDS dinosaur who has followed the HIV epidemic from the very first cases in the early 1980s through the triumph of antiretroviral therapies, a triumph unequaled in the annals of medicine. This triumph has its flip side. Younger colleagues are no longer familiar with the opportunistic diseases and the myriad manifestations, hence the idea of these videos. After a short introduction, they will show a series of images illustrating one or several exemplary cases from my files. Progressive multifocal leukoencephalitis, PML, is an opportunistic infection due to reactivation of latent JC virus. It occurs in patients with low CD4 count. It presents with variable neurologic signs and symptoms, and it's rapidly progressive and lethal, except when immune deficiency can be corrected by highly active antiretroviral therapy. JC virus was named for John Cunningham, a patient who died of PML. Other names are human papillomavirus too. It is a small DNA virus which infects 70 to 90% of the human population. On the left, an artist's rendering of the structure of JCV. On the right, a schematic drawing of JC's genome consisting of 5,100 base pairs of double-stranded DNA. PML is a relatively rare complication of HIV infection. In the Swiss HIV cohort study, PML amounted to 1.8% of AIDS-defining opportunistic diseases in the 1980s and 1990s. The frequency of PML seems similar across all HIV risk groups. There is a clear-cut influence of highly active antiretroviral therapy. In a nationwide study in Denmark, for instance, there were 3.3 cases of PML per 1,000 patient years pre-heart and only 1.3 post-heart. In the Swiss HIV cohort study, the graph shows the number of yearly cases from 1991 to 2001. There was an average of 23 cases per year from 1991 to 1996 and 6 cases per year from 1997 to 2001 after the introduction of heart. Symptoms depend on where the lesions are. Hemiparesis, gait disorders, aphasia, visual defects, confusion, disorientation, etc. The MRI and CT show discrete foci of loss of myelin that do not conform to cerebrovascular territories and exhibit neither mass effect nor contrast enhancement. MRI is more sensitive than CT and may show additional lesions. These are hyperdense with decreased signal in T1, increased signal in T2 with no gadolinium enhancement. A word about the value of DNA amplification for GC virus in the cerebrospinal fluid. Studies from the 1990s established a sensitivity of some 80% and a low false positive rate, but improvements in technique suggest that now sensitivity should be higher. In any case, low concentrations of GCV DNA or absence of JCV DNA correlate with better prognosis. JC virus is also present in blood mononuclear cells, but this is true also of persons without PML, and levels are not higher in PML than in control patients. Survival is prolonged by heart. For instance, in one series, more than half of patients were alive 1 year after diagnosis, compared to less than 10% in historical controls. None of multiple experimental drugs supposedly active on the JC virus itself have proven effective so far. Often neurologic sequelae are important. On to some case studies. The first patient consulted after a fall and because he bumped into obstacles. T2 weighted sequences showed hyperintensities in the white matter of the right parietal and occipital lobes. 8 weeks later, these hyperintensities have markedly increased in size, extending now into the left internal capsule and to the white matter of the left parietal lobe by extension through the splenum of the corpus callosum. In T1 weighted images without injection of gadolinium, one can see extensive hyperdensities corresponding to loss of myelin. Here is another example of rapid progression with a small lesion in the left occipital lobe on July 4th and ipsilateral and contralateral extension across the corpus callosum on August 17. A 9-year-old boy, HIV infected, presented with right hemiparesis. The CT scan showed enlargement of the ventricles and hyperdense regions. The MRI shows lesions of the white matter without mass effect nor gadolinium enhancement. Cerebrospinal fluid was positive for JC virus after gene amplification. These findings are typical of progressive multifocal leukoencephalopathy, although the disease is reputedly uncommon in children. The CT scan is less sensitive than the MRI. The CT scan on the left and the T2 weighted MRI scan on the right were taken within 3 days of each other. Autopsies of patients who died of PML show extensive loss of myelin, colored green in these photographs. Note the lack of symmetry between the two cerebellar hemispheres. Demyelinated foci contained atypical oligodendroglia with intranuclear inclusions characteristic of JC virus. On the left, an enlarged oligodendrocyte full of dense materials which correspond to mature JC virions. On the right, a transmission electron micrograph of JC virions in neural tissue. Immunohistochemistry with an antibody that stains JCV-infected oligodendrocytes. PML and immune reconstitution disease. Symptoms of PML may appear or pre-existing symptoms may worsen when heart is introduced. This represents a dilemma. Without heart, prognosis is dismal, but the transient worsening may leave behind permanent sequelae. A few examples follow. This patient underwent a brain biopsy when symptoms worsened after introduction of highly active antiretroviral therapy. The image on the right shows a mononuclear infiltrate in the biopsied tissue, staining positive for CD8, which would be characteristic of an immune response to the JC virus. In November of 2000, this patient presented with depression and gait disturbances. HIV infection and PML were diagnosed and highly active antiretroviral therapy was started. During the next 6 weeks, the patient became hemiplegic and aphasic. The CD4 cell count increased from 32 to 300. HIV viremia disappeared, but the serious neurologic sequelae persisted. In July 2001, atrophy of the left temporal and parietal lobes with expansion of the fourth ventricle are evident. The patient committed suicide 2 years later. A 26-year-old woman presented with extrauterine pregnancy. At laparoscopy on June 10, 2006, the surgeon, who was from a developing country, diagnosed tuberculous peritonitis. Biopsy and culture confirmed this. The CT scan showed extensive lymphadenopathy. The HIV test was positive and the CD4 count only 18 per microliter. TB therapy started June 11th and heart August 24th, 2006. A month after starting highly active antiretroviral therapy, she complained of vertigo and oculomotor disturbances. The MRI showed lesions in the cerebellum and brainstem without mass effect or uptake of gadolinium. JC virus was found in the cerebrospinal fluid. She continued to complain of vertigo and couldn't walk normally for several months, but eventually recuperated. The most important differential diagnosis of PML is HIV-associated dementia, also called AIDS dementia complex. Both affect primarily the white matter, do not enhance with contrast media, and have no mass effect. However, lesions of PML are asymmetric and rapidly progressive. Only 8 weeks elapsed between these two images. The lesions are quite spectacular in T2 and fluid attenuation inversion recovery, and there is no volume loss. In contrast, lesions in ADC are symmetric. The disease progresses more slowly. There is only discrete signal enhancement in T2, and volume loss may be pronounced. Thank you for watching, and thanks in advance for your feedback. This video is part of a series on opportunistic diseases in HIV/AIDS. If you are interested, please subscribe or click on the latest upload top left.